Welcome to the second module in the Outbreak Management training presented by the Thunder Bay District Health Unit IPAC Hub team. This two-part series is designed for our long-term care, retirement homes, and acute care facilities and provides an overview on how to identify, report, and manage enteric and respiratory outbreaks within their facilities. This presentation has been updated in November 2022 to represent ministry guidance changes that occurred in October 2022. If you have not listened to Module 1, we recommend you stop and first listen to Module 1 prior to completing this module. This module is a recorded presentation. Feel free to pause the presentation at any time to learn at your speed. If you have any questions, please do not hesitate to email us at ipachu@tbdhu.com. For congregate living settings that are not a retirement home or a long-term care home, we recommend you visit our Congregate Living Settings Respiratory Management module found online at our website. At the health unit and with our Ontario ministries, there tends to be a large use of acronyms. So we started to collect some of the acronyms here for your review, just in case any of these are new for you. So TBDHU stands for Thunder Bay District Health Unit. PHO is Public Health Ontario. OMT will be Outbreak Management Team. OB is for Outbreak. IPAC or IPAC is Infection Prevention and Control. HH stands for Hand Hygiene. ABHR is Alcohol-Based Hand Rub. PPE is Personal Protective Equipment. PP or PNP is Policies and Procedures. LTCH is Long-Term Care Home. And RH stands for Retirement Home. There is a lot of material for us to go through. Since this is a recording, go through the material at your pace. Take breaks when you need to by using the pause button. In the first module, we reviewed outbreak processes and control measures. Today's modules will discuss enteric outbreaks, information, guidance, and control measures that are implemented in addition to normal outbreak control measures and specific to enteric diseases. For respiratory outbreaks, we'll provide information, guidance, and control measures specific to respiratory diseases, namely influenza and COVID-19.
At the beginning of the presentation, we discussed briefly what an enteric outbreak is. It involves infectious agents that affect the gastrointestinal tract and can also be referred to as gastroenteritis, which causes symptoms such as abdominal pain, nausea, vomiting, and/or diarrhea. Many different agents can cause these same symptoms, from bacteria, parasites, or viruses. Two common examples is norovirus, which was first made newsworthy by cruise ships, and salmonella, a bacteria commonly associated with undercooked chicken or eggs. Both of these can spread human to human and are common in outbreaks. Enteric outbreaks continue to represent a significant burden of illness in congregate settings. Approximately 1,000 to 1,200 gastroenteritis outbreaks are reported annually to public health. The number of cases associated with a single outbreak may range from 10 to 200. This can be dependent on the size of the home. Outbreaks may be smaller in size as well. Gastroenteritis outbreaks in healthcare facilities occur most frequently between November and May, but may occur at any time of the year.
Enteric outbreak case definition is defined in the Infectious Disease Protocol, Appendix B, gastroenteritis outbreaks in institutions and public hospitals. The case definition is as follows: 2 or more episodes of diarrhea within 24 hours, or 2 or more episodes of vomiting within 24 hours, or 1 or more episodes of diarrhea and 1 or more episodes of vomiting within the 24-hour period. So think 2 diarrhea, 2 vomiting, or 1 and 1 diarrhea with 1 vomiting. Ensure that episodes of diarrhea and vomiting are abnormal for the individual. So you would want to rule out any other causes to these: medication side effects, new diets, is this common with their diets, medical condition, or if they've been given laxatives or prunes. In the same appendix, the Appendix B, suspected outbreaks are discussed, however, they are not defined. There is no definition with the amount of cases. However, at any time an outbreak is suspected, even an early detection, it must be reported to the health unit. It is better to be cautious and have the resources and staff prepared at the public health unit rather than scrambling. We would rather be alerted and it not progress over than it not be notified until you're already in outbreak. There's typically a public health nurse on call or after hours, or if not, a covering manager. So there's always someone that you're able to report to. You don't have to wait until normal working hours in order to report it. So here is an example when an outbreak could be suspected. A floor 2 of a facility has a resident with 1 episode of vomiting and 1 episode of diarrhea with the onset on December 1st. These episodes are very abnormal to this client. A staff on the same floor who assisted this resident with the symptoms has now noted they have vomited on the next day, December 2nd. So this staff member doesn't meet a case definition with only having 1 episode. However, an epidemiological link exists between the 2 cases, or the case and the staff member, and it's not normal for the staff member to vomit either. It would only take 1 more episode of vomiting or diarrhea by that staff member for the staff to become a case and then an outbreak to be declared. So this would be a good example of when it would be a suspected outbreak. An enteric confirmed outbreak. So this definition is also brought to us by the Infectious Disease Protocol Appendix B. So a confirmed case is defined and is when there are 2 or more cases with an epidemiological link within 48 hours. So it doesn't take too much to declare an enteric outbreak. So again, to ensure those symptoms are true, which Courtney's going to speak to next. So some examples would be on floor 2, that resident has 1 episode of vomiting and 1 episode of diarrhea on December 1st. And then another resident on the same floor has 2 episodes of diarrhea 2 days later. So that's within 48 hours. There are 2 individuals on the same floor, a meeting case definition. So that would confirm an outbreak.
Ruling out non-infectious causes. Earlier, we spoke to symptoms, but it is important to rule out non-infectious causes of symptoms that could be attributed to medications, diet, or a medical condition. Ruling these out ensures that the symptoms are abnormal to the client and not caused by anything else. Those who care for the client may be able to determine this easily. However, if there is ever a doubt, it must be considered to be a true symptom of the infectious agent or outbreak. Residents may not be able to report some symptoms, for example, nausea or abdominal pain. Careful observations are needed to determine if these symptoms are occurring. This could be behavioral changes in clients that aren't able to verbalize that they are experiencing any nausea or pain, for example. Frail residents with small appetites may only have 1 episode of either vomiting or diarrhea and may or may not exhibit other signs and symptoms associated with gastrointestinal illness. These residents may be considered suspect cases, and infection control measures are implemented to prevent potential transmission. Viral gastroenteritis, as opposed to bacterial infections, is the leading cause of enteric outbreaks in most facilities, especially during the winter months when community incidence is also high. In care facilities, norovirus is the most common infectious agent identified and affects both residents and staff. The routes of transmission of norovirus and other viral bugs are through droplets, so emesis or vomiting, direct or indirect transmission, and eating or drinking contaminated food or beverages. Outbreaks of norovirus include the sudden onset of symptoms. Nausea, vomiting, and diarrhea are common symptoms as well, and can lead to a high rate of secondary transmission. Because of the symptoms, it allows for more spread. Acute explosive vomiting and diarrhea spreads higher viral loads around. A propagated epidemic curve, as shown on the slide, demonstrates how person-to-person or secondary transmission can be extremely high with norovirus. Although there may be a common source, such as food items, that is responsible for an outbreak, secondary transmission from person to person can and does readily occur. Infected individuals typically shed millions of viral particles in their feces or emesis, but only a few are needed to cause infection. This is called a low infectious dose and adds to the spread, as you can see on the graph, will create spikes in cases beyond the initial exposure. Bacteria and parasites are less often the cause of outbreaks, but they can occur. Some bacterial pathogens, such as Shigella and varotoxin-producing E. coli and Salmonella typhi, require special considerations. Their initial attack rate may be higher, but the transmission between person to person is less common, leading to a greater success in controlling the outbreak.
So, steps within the investigation of an enteric outbreak. Thunder Bay District Health Unit public health inspectors respond to enteric outbreaks. This is to rule out a common source causing the outbreak and help to prevent any further spread. So, a common source would be an example of contaminated food, water, or an ill person working within the kitchen. So, you would see a lot of people become ill in a very short period of time, all at the same, right around the same time. So, in order to rule that out, the inspectors may take water, ice, or food samples and have them tested to ensure that none of the food, water, or individuals are contaminated. Outbreaks can also spread from person to person after an initial source, and that can result in a high secondary rate of infection. So, an example of this occurring could be norovirus being in a food item. Maybe it's not a commonly chosen food item and only a small amount of the population gets sick. However, the spread between individuals when symptomatic is very high. So you would see a small peak to start and then a very large peak afterwards. And again, inspectors would have to identify this and help rule it out as well. In addition to inspecting all food preparation areas, the investigation could also include the collection of information from residents, staff, and others who may have been exposed to contaminated food or water, clinical samples from staff. This includes both symptomatic and non-symptomatic staff. This could be directed to rule out healthy carriers of an infectious agent while working within the kitchen.
Enteric outbreak measures. Once an outbreak is suspected or declared, outbreak control measures must be put in place to contain the outbreak. These measures are put in place to lessen the duration of the outbreak and reduce the spread to additional staff and residents. The two documents on the screen are what public health uses to guide the decisions and measures in outbreak, not only in long-term care, but most congregate facilities as well. Appendix B also gives an overview of outbreak management for hospitals and healthcare facilities. Most outbreaks are ran the same way. As a recap of IPAC outbreak control measures, we're going to pause here and review. Your facility is now in outbreak. What is next? It is important to remember the basic IPAC outbreak control measures, which include facility, unit, and resident door signage, communication to staff, clients, families, and visitors, set up PPE stations where required, increase hand hygiene, quantity, locations, signage, and auditing, initiate enhanced environmental cleaning protocols and staffing, and engage your staff with ongoing education around IPAC, including PPE, hand hygiene, physical distancing, etc.
Specific control measures. Transmission-specific control measures or precautions are put in place as soon as individuals are experiencing these symptoms. We shouldn't wait for an outbreak to be declared to implement measures. If you are in outbreak and you're unsure if the client is experiencing symptoms or if the episode is normal for them, control measures should still be in place until other reasons can be ruled out. Always err on the side of caution. Transmission symptom or specific control measures include droplet precautions, contact precautions, and routine hand hygiene. Droplet precautions may be in place if a predominant symptom is vomiting, as infectious droplets can be released during this. Contact precautions must be in place to reduce the spread of infectious fecal matter or droplets, as clients can directly or indirectly infect others or themselves again. Routine practice of hand hygiene will help eliminate any fecal-oral route transmission. If the causative agent, so the bacteria or virus, is known for the enteric outbreak, this may designate if contact precautions are needed, if they're being droplet or contact. Personal care risk assessments, or PCRAs, are applicable, as these specific control measures create the minimal level of precautions, but based on your PCRA, you may need to initiate additional precautions. Control measures for ill residents. Ill residents who are line listed in an enteric outbreak must minimally be placed on contact precautions within their room until 48 hours after their symptoms are resolved. However, if the outbreak is confirmed to be norovirus, then the cases must be isolated for 72 hours instead of the 48. Droplet precautions, so includes masking and the use of eye protection, may also be needed depending on their symptoms. For example, if they're vomiting. This is one of the reasons why it is important to identify the infectious agent as early as possible within an outbreak. If norovirus isn't identified until later in the outbreak, clients may be released a day too early and contribute to further spread within the facility. Facilities who have experience with norovirus outbreaks and are currently experiencing an outbreak with noro-like symptoms may consult with their outbreak management team and follow norovirus guidelines with the 72 hours isolation, even without laboratory confirmation. Many times do we hear, if it walks like a duck and quacks like a duck, it's likely a duck. With any outbreak, we highly encourage to keep residents within their room, but do understand this can be difficult. Outbreak management teams should be notified of these situations and assist in implementing extra precautions, such as supervising the hand hygiene of the cases and increasing the frequency of environmental cleaning and disinfecting on the unit or floor to help prevent the spread to other residents. Resident control measures. When possible, it's always ideal to isolate ill residents within their own room. When it's not possible, cohort individuals with the same symptoms. If the outbreak is not facility-wide and confined to one area of the facility, ensure the residents or clients stay within their own area and avoid cross-mingling. Examples would be floor 2 clients would stay on floor 2. They wouldn't allow floor 1 clients to enter the second floor, or clients from floor 2 enter floor 1. Well, residents are allowed to leave the facility, but should be asked not to visit other healthcare institutions to ensure outbreaks aren't brought to other facilities. Staff and volunteers working in the outbreak. When it comes to staff, students, and volunteers, their movement should be minimized between the outbreak area and any area of the facility that is not an outbreak. They should be cohorted to the outbreak or non-outbreak areas and dedicated staff to work with only the ill individuals. Where possible, recovering staff who are returning to work should be caring for symptomatic residents, as they have a low chance of reinfection. Sometimes this is not all possible, but the more you implement, the better chance the outbreak will be short-lived. Staff and volunteers should be cohorted and not take work breaks with other cohorts.
Recommendations and restrictions for ill staff. Staff and volunteers presenting with gastrointestinal illness or symptoms should not enter the facility, but should report the illness to their supervisor, who will report it to the ICP or follow the reporting procedure of the facility. Staff, students, or volunteers with gastroenteritis should be excluded from work duties for at least 48 hours after symptoms have resolved. Once a specific causative agent is known, disease-specific exclusions would apply. All ready-to-eat foods, i.e., food not to be cooked, prepared by dietary staff that became ill while on shift, should be discarded. During an enteric outbreak, staff from other departments should generally be restricted from entering the outbreak area of the facility if not necessary. If they must enter, they must don appropriate PPE, including a gown, gloves, and mask, to be on the unit. Ensure staff are practicing good hand washing before leaving the outbreak floor or unit. Any equipment that they bring with them should be wiped down with appropriate disinfectant before it leaves the unit. This could be physiotherapy, coming to do an essential session with clients, or dietary, bringing food up on the elevator. Dietary staff could wheel the cart off to the floor staff, whom take it for distribution, to avoid being on the unit if feasible. If it's safe, for example, maintenance staff who need to enter a group home that is an outbreak, ensure they have proper PPE available to them at the door and education and/or assistance for donning and doffing as appropriate. Recommendations regarding working at other facilities during an enteric outbreak. If the facility is an outbreak, before a staff member is scheduled to work at another facility, the staff should wait until 48 hours have passed from the end of their last shift at the outbreak facility. Generally, this would still be up to the facility who is not experiencing an outbreak if they want that staff member working at their facility. Each facility may have different policies and procedures regarding these stipulations. These restrictions may be modified once the infectious agent is identified.
With all outbreaks, admissions of new clients to the outbreak area is generally not permitted, as we don't want to increase the amount of people exposed to the agent and prolong the outbreak. New admissions may occur to areas not affected by the outbreak, but their new admissions should be notified of the outbreak and may opt to postpone, as there's always the possibility of an outbreak spreading facility-wide. Readmissions can be permitted if they've been adequately accommodated. An example would be if a resident is on the line list, so they've been symptomatic or positive, and leave for the hospital due to their need for additional medical care. They are generally allowed back to the outbreak unit if the facility can properly support them, as they've already been accounted for on the line list and are not someone who hasn't already been exposed. Continuing from the previous slide, the following direction is for long-term care or retirement homes and is mainly black and white messaging. But for all our other congregate settings, this is a best practice. Residents of the facilities that were not in the home, perhaps away on a holiday or in the hospital due to other reasons when the outbreak was declared, they have not been exposed to the outbreak or the agent causing the outbreak within the facility. Therefore, they should not be readmitted during the outbreak. This will protect them from being exposed and also protect the facility from prolonging the outbreak and the control measures. We also do not allow for the transfer of residents from anywhere in the facility that is experiencing an outbreak to another long-term care or retirement home. As we know, a contained outbreak can advance to facility-wide, and this can put other facilities at risk. Transfers are stopped as they could be incubating, not showing symptoms but could be infected, and could spread the outbreak to the other facility. The same thing goes for within the facility. It's best to delay any internal transfers. So example, if the outbreak is on floor 1 and you're looking to transfer a client from floor 1 to floor 2, delay this. Admission and returns from absences. When these restrictions are put in place, we also understand the snowball effect this may create, such as backlog at the ER or in acute care. If there are unique situations where the benefits of admission or return from absences outweigh the risks of that admission, it will have to be addressed by the outbreak management team, and Thunder Bay District Health Unit may have to consult with our medical officer of health to allow this. The outbreak management team, when looking at such cases, will look at certain key factors such as the outbreak status. Are they anticipating to declare the outbreak over the next day? Is the outbreak under control? Is the facility able to protect the new admissions? These are all questions they have to ask and assess before they can consider if they can do the new admission. There's also a tool to assist in such decisions, and we're going to take a look at that quickly on the next slide. So this is the tool for long-term care homes and hospitals, but the basis of it can be applied to all facilities as well. It is Appendix 15 from the Recommendations for Control of Gastroenteritis Outbreaks in Long-Term Care Homes, and it's a Ministry of Health and Long-Term Care document. So we're not going to go over the logarithm today, but I wanted to make sure everyone knew that this tool is available. But you would have to use it in conjunction with your outbreak management team. And again, it just goes over the same type of questions we were talking about previously. Are they ready to accept that transfer? And if the status of the outbreak, is there any medical concerns? So they kind of break it down and just to help to assist in that decision.
Visitors. When it comes to visitor restrictions in an enteric outbreak, closing the facility completely to all visitors is not recommended, since this may cause emotional hardship for both the residents and their relatives. But it may be encouraged for non-essential visits to be postponed. Additionally, signage that states where in the facility is experiencing an outbreak is an essential part of communication for visitors. Is it facility-wide, only affecting Unit 2, etc.? It is best practice for facilities to post signage as it ensures any visitors, contractors, etc., who may not get a phone call or notification prior to arriving to the site are aware of the restrictions in place and instructions to follow when entering the facilities. This should be implemented quickly. As mentioned, visitors should be encouraged to postpone any non-essential visits, but if visits are deemed necessary, the visitors should be instructed to go directly to the room, have their visit, and then directly leave, ensuring they are not stopping to socialize in the hall or visit or check in on any other residents. This could cause spread or transmission and may lead to the outbreak being extended. Additional measures to ensure and enhance visitor monitoring include providing strict guidance and education to each visitor on proper hand hygiene and the wearing of PPE if applicable, and instructions to avoid communal areas. COVID has introduced new innovative ways and opportunities to communicate during isolation or outbreaks. Many facilities have increased their communication technology. There may be options for FaceTime or Zoom visits during the duration of an outbreak or window visits, etc. Most clients within our homes are elderly and or ill or immunocompromised and vulnerable, so unique situations and visitor restrictions should be addressed at the OMT meetings. Ill visitors should be advised not to visit while experiencing symptoms of gastrointestinal illness and until 48 hours after their symptoms have resolved. Visits from outside groups should also not be permitted for the extent of the outbreak, such as external entertainment, caroling, live bands, kinder music, etc., and ensuring internal communications are distributed to residents, families, staff, and volunteers to notify and reinforce these measures. Communication is important and time sensitive. Having a prepared script for staff that promotes consistent messaging to all families is important. Most congregate facilities remain in COVID screening. It is important to stay vigilant in screening. If your facility is experiencing an enteric outbreak, it would be beneficial to add those screening questions that are relevant to that outbreak. Seize the opportunity to ensure visitors are aware of the outbreak during the screening process. Have they received recent PPE training, etc.? Communal activities. Communal activities should be rescheduled on the affected unit or floor during the outbreak in your facility. Meetings and activities may proceed in non-affected areas only, but any group outings from the affected unit or floor should be discontinued. On-site adult programs such as physiotherapy and foot care may continue for the well residents only, however, they must be provided within their rooms. The OMT should discuss restricting meetings and activities for the entire institution if the outbreak spreads to 2 or more floors or units.
Environmental cleaning and laundry. There will be an increased need of environmental cleaning or housekeeping and laundry staff due to symptoms of the enteric outbreak. So symptoms can often be urgent, increasing bodily fluid spills, and also soiled laundry. All of these have the means to transmit disease to staff as well. It is ideal to have housekeepers dedicated to only work on the affected outbreak area. So again, cohorting staff and ensuring there's an adequate amount of staff to keep up with the increasing cleaning, which I assume we're kind of familiar with past COVID cleaning protocols. And also enough staff if any staff are to become sick, that there is that backup as well. Ensuring that all the high-touch surfaces and common areas are cleaned and disinfected throughout the day, and also the bathrooms, and this will help reduce transmission. Housekeepers within the affected outbreak area should clean in the well residents' rooms before attending to the clients with symptoms or those who are ill, and this is also to help to reduce the risk of transmission. The housekeepers must also be supplied with adequate personal protective equipment or PPE that they can utilize when entering the ill client's room. Ensuring these staff are re-educated and reminded of the proper donning and doffing of PPE is paramount, as they may not utilize it as much as other frontline staff. So ensuring they are knowledgeable and they feel secure in their procedures is really, really important. Laundry staff will also have to use PPE due to the soiling with the infectious agents, so vomiting and diarrhea. So they should also be re-educated and reminded of their use as well, and ensuring that they're confident in their use before going into these rooms or handling anything that's soiled. Ensure they know when to use the PPE and how it should be changed. Masking is always recommended when handling soiled laundry and moving it into the machine. However, right now, this is a common practice with universal masking within our facilities. This can change as the pandemic changes as well. So keep this in mind and remind the staff as well to always change their mask after they have that exposure to that soiled items. So the enteric outbreak, let's just do a recap. There was a lot of information and we just want to ensure that some of the important points are remembered. So always ensure the symptoms are true and abnormal for the patient. So you're going to rule out laxatives or medications before they're added to the line list. Detect early and notify at the same time. There is no harm in suspecting an outbreak and it not being declared. It is better to have the public health unit available and aware with its resources than coming up and saying you're an outbreak. Obviously, this isn't always doable, but if you are suspecting something, that's when you call us as well. Increase hand hygiene by everyone in the facility, and increase environmental cleaning in the common areas, and implement those additional precautions quickly. It is ideal to identify the infectious agent and can sometimes be difficult to collect, so start trying to collect a sample immediately. It's preferable to have it from a client who is the most recently symptomatic. So rather than trying to collect from an individual who started symptoms 2 days ago, try to collect from the person who's starting with the symptoms that day. Get that signage up quickly. That's going to provide adequate communication and direction for staff and also visitors. Utilize the outbreak management team. That is where problem solving occurs, and this is a multidisciplinary team, so that allows for such conversations to occur. Keep unwell residents within their room the best you can. Cancel any non-essential activities and cancel any new admissions. So we've already gone over outbreak process and general outbreak control measures within the first module. In this module, we have now applied these concepts to enteric outbreaks. The rest of this module will be us applying outbreak process and control measures to respiratory outbreaks. Respiratory outbreaks. So fall to early spring, which is usually October through April, is where we spend more times indoors in the Thunder Bay area. Being indoors, we're in closer quarters, and this allows diseases that spread through droplets to spread quickly. Therefore, we always see a spike of these respiratory diseases in our region during these times of the year. Obviously, we've been living through our current COVID pandemic for over 2 years, but locally we continue to see waves or spikes in cases during the fall to spring with COVID as well, it being respiratory illness. Respiratory disease is also common in our congregate settings due to the close living quarters and many shared common indoor areas, and in residents that typically have a lowered immune system due to their age or health. So here's a list of some of the common respiratory viruses that are more associated with respiratory outbreaks. Influenza A or B, enterorhinovirus, coronavirus, RSV, which is respiratory syncytial virus, parainfluenza, or metapneumovirus, and also COVID-19 pandemic that we're still currently navigating through.
Outbreaks of COVID-19 and other respiratory viruses are going to be defined slightly differently from each other. Influenza or other non-COVID infections will be defined based on a provincial case definition, which is indicated in what we refer to as Appendix B. COVID-19 outbreaks are declared based on the provincial outbreak definition relevant to the type of facility. For example, 1 versus 2 cases of COVID as per the ministry guidance documents. However, as we've progressed throughout this pandemic, the criteria for COVID-19 outbreak definitions have changed in most settings to now include 2 confirmed cases, but we will discuss this further in detail in the following slides. Respiratory case definition. So again, respiratory case definitions will vary based on the infectious agent that is suspected or identified. The case definition for each facility's unique outbreak will be developed in collaboration with the health unit using the guidance in Appendix B and/or the ministry documents. The case definition for a general respiratory outbreak must include at least 2 or more of the respiratory symptoms or a lab confirmation of a respiratory agent. The defining symptoms include fever or abnormal temperature or chills, new worsening cough or shortness of breath, runny nose or congestion or sneezing, sore throat or difficulty swallowing.
COVID-19 case definition. The case definition for COVID-19 has been updated and is current as of June 2022. This information may change throughout the course of the pandemic, so we encourage you to please check the Ontario Health website often for updates. A person with confirmation of SARS-CoV-2 infection is documented by 1. Detection of at least one specific gene target by a validated laboratory-based NAAT assay, so a real-time PCR or nucleic acid sequencing performed at a community, hospital, or reference laboratory, as in Public Health Ontario Laboratory or the National Microbiology Laboratory, or a validated point-of-care NAAT that has been deemed acceptable by the Ontario Ministry of Health to provide a final result. Or lastly, it's demonstrated seroconversion or diagnostic rise of at least fourfold or greater from baseline in viral specific antibody titer in serum, plasma, or whole blood using a validated laboratory based serological assay for SARS CoV 2A. So let's review the definitions of respiratory outbreaks, starting with suspect outbreaks. This can be identified a few different ways and can get confusing with COVID, influenza, and other respiratory illnesses. A suspect respiratory outbreak is 2 cases of acute respiratory illness occurring within 48 hours with any common epidemiological link, so having those 2 cases on the same unit or floor. If influenza is suspected, it's having more than one unit having a case that meets definition within 48 hours or one laboratory confirmed case of influenza, and this can be a staff or resident. For COVID-19, it is having one positive lab case in a resident. The surveillance definition of COVID-19 outbreaks in long-term care homes and retirement homes are as follows. A suspect outbreak in a home is defined as one positive molecular test in a resident where source of acquisition is thought to be from within the home or cannot be determined.
To confirm an outbreak, so a non-COVID respiratory outbreak, it can occur in 2 different scenarios. So 3 cases meeting the definition within 48 hours with a common epidemiological link. So that would be on the same floor or on the same unit. The second scenario would be 2 cases meeting the definition within 48 hours, one of them being laboratory confirmed. You can see the diagram there depicting the situation as well. On the next slide, we'll go through respiratory COVID.
COVID-19 confirmed outbreaks. Surveillance definitions of COVID-19 outbreaks in long-term care homes and retirement homes are as follows. A confirmed outbreak in a home is defined as 2 or more residents with a common epidemiological link, so the same unit, same floor, etc., each with a positive molecular or rapid antigen test within a 10-day period. An epilink is defined as reasonable evidence of transmission between resident staff and visitors, and that there's a risk of transmission of COVID-19 to residents within the home. It's important to note that the definitions above are for surveillance purposes only. Public health units have the discretion to declare a suspect or confirmed outbreak based on the results of their investigation, including when the above definitions are not completely met. All positive molecular tests or rapid antigen test results in residents, staff, or visitors associated with a suspect or confirmed outbreak in the home must be reported to the public health unit and outbreak management team.
Okay, so a recap of IPAC outbreak control measures that we learned about in the first module. So you're in a respiratory outbreak. What's next? So remember those basic IPAC outbreak control measures. So the facility, the unit, and the resident areas need door signage. So that indicates to anyone coming into that facility that an outbreak exists and provides them information regarding that. That clear communication to staff, clients, families, and visitors so they know what's going on, they know what to expect, ideally before they show up. Having those PPE stations where required, it's really important, and getting that up fast as possible. You're going to increase hand hygiene, so you're going to the quantity of hand hygiene, the locations might be new or in addition, signage about hand hygiene, and then auditing that hand hygiene during an outbreak. You're going to initiate enhanced environmental cleaning protocols and staffing to keep up with the common shared areas and then with the ill residents. And then you're going to engage with ongoing education around IPAC. So education about that PPE, how to use it, when to use it, how to put it on and off, where to store it. Hand hygiene, reminding staff, reminding residents, visitors. And then depending on it, but I think a new thing we're going to see a lot of is physical distancing, especially with COVID. One additional piece of PPE that should be of interest during a respiratory outbreak would be N95 masks. So ensure staff are fit tested and there are adequate supplies as well. Typically, we do like to remind facilities in the late summer and early fall that this is a good time to look at your fit testing program and ensure that everyone required to be fit tested is completed by the end of September. September seems to be a good month as there's less employees on vacation. Most are back to work or back to school, so they're getting back into their routines. It's a little bit cooler, so again, less traveling. So looking at it in August, setting up for September is quite ideal.
Specific control measures. During an outbreak, specific control measures are put into place with the goal of bringing the outbreak under control quickly. We talked about PPE, signage, and all those IPAC control measures. These all need to be implemented as soon as the outbreak has been declared. When it is a respiratory infectious agent or outbreak, the transmission-specific control measures will reflect the ways in which the infectious agents can be spread. So through droplets, cough or sneezes, airborne through aerosol-generating medical procedures, or AGMPs such as CPAP or high-flow oxygen, or contact of an infectious person or their environment. The little diagram on the screen shows the different routes of transmission of respiratory agents and how they can be spread. Once the infectious agent is identified, it may also change the type of precautions that are put in place. For example, if droplet contact precautions were initiated, but then the infectious agent is identified as TB or tuberculosis, the precautions would need to change to airborne and contact, as that specific disease can be transmitted via airborne route without the presence of AGMPs. Additional precautions for respiratory non-COVID. Symptomatic clients should be placed on droplet contact precautions and isolated to their rooms with meal tray service. This would be in place until 5 days after the onset of acute illness or until symptom-free, whichever is shorter. If the case does not have a private room, roommates should be assessed, tested, and could also be placed under droplet contact precautions. Some pathogens may be longer, and if identified, they need to be determined in consultation with the OMT. Additional precautions for COVID-19. Advice and recommendations have changed as we've progressed through this worldwide pandemic. The most current Ontario guidance for long-term care and retirement homes as of October 6, 2022, advises that all symptomatic or positive clients are to be placed on droplet contact precautions and isolated to their rooms with meal tray service for 10 days from symptom onset or date of specimen collection if asymptomatic. Roommates who are close contacts should be placed on additional precautions once identified. If the close contact roommates remain asymptomatic, they may discontinue isolation after a minimum of 5 days following a negative molecular COVID-19 test taken on or after day 5. In general, all other non-roommate resident close contacts within the unit and facility who remain asymptomatic do not need to self-isolate or be placed on additional precautions. Resident close contacts should be monitored twice daily for symptoms and strongly encouraged to wear a well-fitting mask if tolerated and physically distance from others when outside of their room for 10 days following their last exposure to an individual with COVID-19.
Special considerations for isolated residents. It can be very difficult to keep clients within their room, especially for extended periods. It can even be more difficult if they are feeling well and not experiencing any symptoms. For other clients, their cognitive abilities or behavioral tendencies can make it difficult to keep them in their rooms or for them to understand why they should stay within their rooms. It is still very important to keep room isolation as much as possible, and those clients who tend to wander from the room should be redirected as quickly as possible. These known clients should also have staff or volunteers spend some extra time with them, remind them of hand hygiene, remind them of masking and respiratory etiquette as well. And that will ensure to reduce spread when the staff are not available to redirect them to their room immediately. Through the pandemic, we feel that each facility has learned lots of different tips and tricks to help with these situations. Um, Although these situations should always still be brought up to the OMT, and strategies there can be discussed. It could it could involve such solutions as dedicating a smoking balcony to keep individuals from going through non-outbreak areas of the facility to reach the previously designated smoking areas. It could also include dedicated time slots for an activity room for some quiet time or a break from isolation with proper IPAC measures in place, or it can include one-to-one walks or sitting time in empty halls and rooms.
Additional precautions for facility units or other floors. It may be necessary to restrict residents to their floor or unit to avoid contact with residents and staff in the remainder of the facility. So that could mean canceling mixed activities such as dining or bingo, and dedicating entrances and exits such as elevators, staircases, break areas, outdoor areas for staff and/or residents of the outbreak floor or unit. Cohorting residents with COVID-19. When cohorting residents in a COVID-19 outbreak, it is ideal for cases to have their own private room. Cohorting residents infected with or exposed to COVID-19 is a commonly used strategy for preventing its spread in a congregate living setting. Many facilities have also opted to utilize off-site cohorting as a strategy by utilizing dedicated isolation facilities to ensure that the mixing of residents with different exposures is limited. Although cohorting residents can also be used in outbreaks of other respiratory viruses, this is not generally done in congregate settings, typically only utilized for COVID-19. Cohorting bathrooms is also an important measure to reduce the spread within a facility. Cohort shared bathrooms to persons or groups based on the health or exposure status can help limit the spread or potential for secondary transmission. If you're unable to cohort bathrooms based on exposure, cleaning and disinfecting between each use of individuals or groups would be required. Cohorting residents for COVID-19. This chart is from the cohorting document from PHO and highlights the ways which cohorting of residents in a COVID-19 outbreak can be done within any setting. It breaks down the exposures of residents to exposed and well, exposed, ill, and COVID negative or unknown, and COVID positive clients. What is important to note here is that the only clients that should be grouped together are those known to be positive for COVID-19. You could have individuals who have been exposed and may be presenting as ill, but without the confirmation of the virus, it could be possible that their symptoms are related to other health processes or even a different virus. So as the chart indicates, residents or clients who have been exposed but are well and those exposed and ill should be kept separate, as we do not know who has been infected and who could be incubating and who may not be. This also comes into play when reminding staff that although all of these individuals may be isolating under the same precautions, they may not all have the same exposures, and some may be incubating and some not. Treat all clients as if they are potentially infected, so protecting yourself with PPE, hand hygiene, etc., but as well treating them as if they are not infected, so protecting the client from secondary transmission and stopping the spread.
New admissions, returns, and transfers. So on this slide is a reference to Appendix E of the COVID-19 guidance for long-term care homes, retirement homes, and other conjugate living settings, which displays an algorithm and flow chart for the different scenarios within the workplaces. Testing and isolation of asymptomatic clients, residents, being admitted or transferred from the community or a facility that is not an outbreak is no longer recommended. Long-term care homes and retirement home residents continue to be required to be screened for symptoms and exposures on admission or transfer. Any resident being admitted or transferred to a long-term care home or retirement home, regardless of their COVID-19 vaccination status, who is identified as having symptoms and/or a diagnosis of COVID-19 must be tested, self-isolated, and placed on additional precautions at the home. Admissions and transfers to a long-term care home and retirement home on an outbreak floor or unit should be avoided in the following circumstances: a newly declared outbreak where there is an ongoing investigation, outbreaks where new cases are occurring beyond those known contacts who have already been isolating, so it's uncontrolled or uncontained, and lastly, admissions or transfers to floors and/or units where many residents are unable to follow public health measures. If absolutely necessary, clients or residents who do not have an active COVID-19 infection may be admitted or transferred to a floor and/or unit with an outbreak, provided the following conditions are met: the resident is up to date on their COVID-19 vaccinations, the client or resident is made aware of the risks of the admission or transfer and consents to the admission or transfer, and the client or resident is admitted or transferred to a private room if there is space for that.
Appointments and absences. Typically, with all outbreaks, any non-essential appointments should be cancelled. Medical care for feet postponed to 2 weeks or when the outbreak is over, if that's possible. Other examples could be chiropractor or a hair appointment. All that can be postponed. Essential or urgent services that can be conducted with the clients should occur in the room when it can. So an example would be, rather than using the common physiotherapy room, the physiotherapy is performed with that client within their room, so they're not breaking that isolation. Urgent appointments are required, can occur, but ensure the receiving facility or office is aware of the client status and that outbreak status. So an example would be a client who requires dialysis at the hospital. They would have to go there for that, and you would want to ensure that there's proper PPE and IPAC measures to reduce any form of transmission during transport and at that other facility. With short stay absences, they should be cancelled during the outbreaks as well and postponed until that outbreak is declared over.
Communal meetings and dining. In enteric outbreak situations, all communal meetings on the outbreak unit or floor must be rescheduled for when the outbreak is over. Communal meetings on units or floors not affected by the outbreak can continue, but if 2 or more floors or units are affected, the Outbreak Management Team, or OMT, should consider canceling as additional spread is at a higher probability. For non-COVID respiratory outbreaks, guidance remains status quo. IPAC measures should be in place, however, communal gatherings are allowed to continue. For COVID, messaging here continues to change frequently. Please follow the most recent directive or guidance document for your facility. Currently, as of October 2022, communal activities are no longer required to be stopped and may continue in outbreak settings for non-isolating residents, which includes communal dining. However, residents within the outbreak area of the home should still be cohorted separately from residents who are not in the outbreak area of the home. For any outbreak, communal and shared items at dining spaces should be discontinued for the duration. This includes any salt or pepper shakers at the table, and also any ready-to-eat snacks and meals should be prepared as individually packaged or wrapped. So for other communal activities, for non-COVID outbreaks, all group outings from the affected unit or floor must be discontinued. Visits from outside groups must not be permitted, so for example, any entertainment groups or volunteer organizations, and there should be no interaction between those on the affected unit or floor and any on-site programs. Again, as mentioned for COVID-19, group activities and gatherings within an outbreak area of the home may now continue or resume for non-isolating residents. In saying this, facilities should direct their focus on the 3 C's with resumption of these activities and implement control measures as needed. The 3 C's being crowding, close contact situations, and any confined spaces with poor ventilation. This can all be further discussed between the public health unit and the facility during the initial outbreak meeting. Certain activities for residents in isolation may also continue. For example, one-to-one walks in an empty hallway with a close contact or case and staff or essential caregiver, both with appropriate use of PPE, as well as staff or essential caregiver supported visits to a designated room other than the residence room
where others are not occupying or traveling through.
Staff cohorting. Cohorting of staff is an additional measure that will help to contain the potential for further spread within your facility. You want to have dedicated staff for ill residents or clients, and separate dedicated staff for well residents and clients if possible. If you have staff who have been previously positive for influenza and/or COVID, they should ideally be dedicated to the positive residents as their risk of reinfection is very low. Generally speaking, if it is possible, you want to have staff only move from caring from the ill to the well after waiting for 72 hours since the end of their last shift with the ill to ensure they are not incubating themselves. Some facilities have found longer shifts, and cohorting teams was a good strategy for staffing during some COVID outbreaks in the past. Moving temporarily from an 8-hour shift rotation to a 12-hour shift ensures there's less turnover of staff throughout a day. Having dedicated staff members working only on one unit if possible as well. You want to minimize the movement of staff, students, and volunteers between units and floors. If only one unit and floor is on outbreak, you should not have staff crossing over to the non-outbreak areas, if at all possible, to minimize the risk of spread to other areas of your facility. Visitor controls. When it comes to visitor controls during an outbreak, all visitor restrictions would need to be discussed by the OMT. The OMT would take a multi-tiered approach to keep the balance of quality of life while also protecting the health of the facility. Signage is to be posted at entrances with the home's outbreak status and details, for example, what unit is affected. Signage is also to be posted informing visitors of the necessary precautions, and visitors should be trained and instructed on how to properly follow additional precautions, donning and doffing, hand hygiene, and any other restrictions such as physical distancing when visiting. During a COVID-19 outbreak, general visitors should be instructed to postpone all non-essential visits to residents within the outbreak area for the duration of the outbreak. Facilities should continue to follow their ministry's most recent guidance regarding visitor restrictions during outbreaks, as these restrictions may vary based on the type of facility and the current level of concern for COVID-19 within the community. Additional visitor controls for any respiratory outbreak would include sending communications to encourage those who are ill to stay home, recommending immunizations to visitors if applicable, and again encouraging visitors to postpone any non-essential visits. Hand hygiene is to be performed when entering the facility. Signage is to be posted directing all entering the home to perform hand hygiene with alcohol-based hand rub or at a hand washing station. There should also be signage directing visitors where they are to sign in or report to upon arrival, and visitors should only visit the person they are coming to see. Visitors providing direct care are to receive appropriate PPE training and follow all additional precautions that are in place. COVID-19 precautions have changed throughout the pandemic. Ensure visitors are adhering to the most current recommendations and policies within your facility when they are experiencing an outbreak. Those measures could include reductions in capacity limits, physical distancing, and masking.
Non-influenza immunizations. Pneumococcal vaccine is available and encouraged for all adults that are over the age of 65 and for residents within congregate living settings. It is government funded and should be encouraged for any new admissions or new hires within our congregate settings that are 65 years of age or older. COVID-19. Keeping up to date with COVID-19 vaccines continues to be one of the most effective ways to protect yourself against serious illness, hospitalization, and death from COVID-19. The mRNA bivalent COVID-19 vaccines are an updated version of the original RNA COVID vaccines that targets the original virus and the Omicron variant, which is currently the dominant variant in circulation in Ontario. Bivalent vaccines are now being administered as booster doses to eligible individuals. Original doses are still being available as well. The bivalent vaccines are formulated to better protect against the currently circulating COVID-19 variants. They can also help restore protection that has decreased since previous vaccination. Thunder Bay District Health Unit continues to run their COVID immunization clinics and are also offering flu vaccines at these said clinics. Influenza immunization. It is recommended annually to protect individuals from becoming infected with influenza, and the vaccine does require 14 days to produce immunity. The sooner it's available, individuals should seek it out as if they're eligible. You should encourage and support all residents, staff, and essential visitors to receive the annual influenza vaccine as early as possible. If required for your facility, keep track of residents and staff who have received their annual influenza vaccine. Ensure staff members are aware of any applicable facility policies with respect to unvaccinated staff members working during an influenza outbreak.
Influenza antivirals. So antivirals are used in different ways when in an influenza outbreak. They can be used on those who are unimmunized, or they can be used on those who are immunized but under 14 days prior to the outbreak. It can also be utilized for clients who are ill to help them fight the infection. If an individual receives their influenza vaccine while taking the antivirals, there will be no interference with their immunity, so they don't counteract one another. If your local public health unit recommends the use of antiviral medication during an influenza outbreak in your facility, they will also be able to assist your facility in accessing those antivirals for the purpose of outbreak management. In long-term care, when the circulating influenza strain is not well matched by the vaccine during a laboratory confirmed outbreak, antiviral should be offered to all staff, regardless of their vaccination status, until the outbreak is declared over.
Working at other facilities during an influenza outbreak is acceptable given that staff, volunteers, and students are protected by either immunization or antivirals. They would have no restrictions on working at another long-term care facility, provided that there is not a significant influenza vaccine drift. Vaccine drift means how well the match is for the influenza season. That being said, staff would follow their facility's policies, but it would also be up to the receiving non-outbreak facility policies if they will accept the staff member working or not. In these situations, often staff are required to choose one location to work for the entire duration of the outbreak out of an abundance of precaution. The long-term care direction on working at other facilities includes staff who are not immunized and not receiving antivirals must wait 72 hours, one incubation period, from the last day they worked at the outbreak facility. Staff who are not immunized but are taking antivirals can work at another long-term care facility if no fever or other respiratory symptoms that does not conflict with the policy of the receiving facility and does not conflict with the direction from TBDHU based on information specific to the epidemiology of the outbreak. For non-influenza, non-COVID respiratory outbreaks, staff would again be required to follow their facility's policies, but the general direction is to wait 72 hours before working at another facility for staff, volunteers, and students. This is reflective of the general respiratory incubation period. If RSV, parainfluenza, metapneumovirus, or adenovirus is identified as the infectious agent, then the length of time is extended to 8 days between, as indicated by the incubation period for those viruses.
Multiple respiratory outbreaks. The possibility we don't want to be reality is that there are multiple respiratory outbreaks occurring in one facility at the same time. And we have seen this locally. There'll be a respiratory outbreak on one unit and then a COVID outbreak on another unit. You could even, if depending on the size of your facility, have a gastro outbreak on an additional unit. In the particular event that there are more than one outbreaks at a time, or more than one respiratory outbreak at the same time, each outbreak is still going to be managed independently. There could be areas of overlap between the outbreaks. So for outbreaks, let's say of COVID-19 and influenza, specific control measures for each virus will need to be implemented. So cohorting of the residents for COVID-19, use of antiviral medication for influenza if indicated. And then the outbreak management team will help with implementing and ensuring that it is the correct areas that are being addressed. So ensure staff, if they should be assigned to work in the outbreak area, they're also not working in the second area. So a quick little recap of respiratory outbreaks. COVID-19 typically needs to be ruled out with testing if someone is showing respiratory symptoms. Testing should be done in order to identify the infectious agent causing the outbreak. So not just ruling out COVID, but trying to figuring out what is causing the outbreak. Knowing the infectious agent at play will determine the length of the outbreak, the length of the additional precautions for the residents, if there's the use of antivirals, needed staffing based on immunization status, etc. So it's really important to try to identify that. Ensure all generic outbreak measures are in place. So again, that's like the hand hygiene, environmental cleaning, signage, PPE station. Ensuring any additional precautions are implemented quickly to reduce transmission. Ensuring all communal activities or outings are canceled as appropriate. Ensuring non-essential appointments or visits are postponed. Any shared items at dining are removed. And depending on the outbreak, all dining could be stopped. It's just dependent. So you are declaring the outbreak over. So communication to your stakeholders and the public. The Thunder Bay District Health Unit can usually do this for you. That's typically decided at an outbreak management team meeting. Communication also within the facility, so with your staff, residents, and their families. Final outbreak meeting when declaring it over will dictate what measures to remove and when. So that's the de-escalation of control measures. Although you're removing control measures, ensure to keep with the routine practices, especially hand hygiene. It's still very important to prevent another outbreak from occurring. You have used a lot of materials during the outbreak, so stock should be checked. So again, looking at hand sanitizer and soap, how much has that depleted? Your personal protective equipment, how much has that been depleted as well? Another way to prepare is to have a debrief meeting with the outbreak management team to discuss successes and setbacks. Many times, how could we prepare better next time is the theme, and having the meeting will assess putting words into action.
Thank you for viewing our two-part series on outbreak management, which highlighted the IPAC measures required in enteric and respiratory outbreaks in long-term care and retirement home congregate settings. We welcome any questions you may have regarding these modules to be sent to ipachub@tbdhu.com.